No? Okay. All right. No then. Olivia, I think everybody's brain is there right now. All right, I gotta turn the sound off real quick so I'm not distracted. So hopefully this will do the trick. All right, there we go. All right, so today we have a nice little variety pack or sampler platter of topics that we're gonna get through. It's kind of like the leftovers, so they're kind of a few little random bits and pieces that we're gonna talk about. But they're all fun bits and pieces, so I'm excited to be talking to you about them. So the first area that we're going to cover, we're going to do a little calcium review, and then we're going to talk about some metabolic bone diseases. And so calcium we talked about in the beginning of the semester, so a little of this should be a review, and if not, it'll be a nice review before you head into your final. But calcium really is essential to many processes that we need to live. And so, you know, kind of my joke here is that if Ron Burgundy is a movie character, so if you don't know Ron Burgundy, he sort of is a self-proclaimed big deal. And I think calcium could be the same. I actually took that quote and read that came from your textbook, and I love it because calcium is so essential to so many things. So when we look at some of the essential pieces that calcium helps with, plays a big role in our bone formation and therefore our skeletal structure, plays a really big role in our nervous system as far as axon excitability and nerve transmission. We need calcium movement to generate muscular contractions, and that's within, you know, our skeletal muscles, but also we need calcium in our myocytes and our cardiac muscles, so we need it for cardiac function as well. In addition, it's not listed on there, but calcium plays a part of our clotting cascade, so it's important for coagulation also. Now, we have a couple of hormones and a vitamin that help to sort of regulate calcium. That's the parathyroid hormone, calcitonin hormone, and vitamin D. And vitamin D is not a hormone. It has a lot of hormone-like properties, but it's not a hormone, and it's essential for calcium absorption, as you'll learn in a few slides. Without vitamin D, we can do all of this hard work to get our calcium where it needs to be, but it won't be absorbed. So vitamin D is just as important as the hormones as far as regulating calcium. The NCLEX loves to ask you guys about nutrition type questions, and so we're going to review these kind of in little pieces as we move through each section. So when you're talking to your patient about calcium sources, it's a good idea to give them examples. You can't say you need to take calcium and then never follow that up because they might not have any idea where to get that calcium. And we have a great resource at our disposal in the hospital that can help us with dietary choices, the dietitian. However, certainly within our scope of practice to get that conversation started, to continue that conversation, and then to follow it up after the dietitian leaves and is done with their education session. So there's a link on the bottom of this slide, and I took that straight from your textbook. It gives you a more comprehensive list of calcium sources. These are just sort of big picture, high calcium content areas. So dairy is very high in calcium, and that's all sources of dairy. So milk, cheese, yogurt. A lot of our green leafy vegetables, like our edgy veggie there, broccoli. Spinach is high in calcium. However, it's also high in oxalates, which is actually a mineral that will break down calcium. So if you're eating raw spinach, you're kind of like counteracting the calcium that you're consuming because those oxalates are going to break a lot of that down. So if you're looking to consume spinach for high calcium values, the best way to do that is to cook it. because cooking it will actually release those oxalates and leave you with just the calcium, so it won't inhibit absorption. Many of our cereals and our milks too, a lot of our processed foods are high in vitamin D and calcium because they've been fortified with it, chemically. We've added it. So I guess that's one win about living in this world of our population generally consumes a lot of processed foods. So one takeaway from that is that vitamin D deficiencies are pretty rare, and calcium deficiencies are less rare, because now we have all of these calcium additives in a lot of our foods, a lot of our processed foods. You know what? Tofu's not on this list, but that's another really popular one. I feel like I see that one all the time in NCLEX style questions, is that tofu is a good source of calcium. All right, everybody okay here? Okay. All right, so on to this fun slide. Let's talk about, I think we talked about osteo, or at least it was mentioned last week, osteoclast. So let's just kind of do a recap. So our bones are kind of like a piggy bank of calcium storage. That's where 98% of our total calcium stores are in our bone. So if our serum calcium level is low, we'll go to our little piggy bank from our bones and we get some. And part of that process is that our bones are constantly remodeling. They're breaking down old bone and then they're building new bone. So our osteoclasts are responsible for breaking down bone. And you'll see these terms kind of used interchangeably here. But bone resorption is breaking down bone. So we're releasing it from the bone, and then it essentially ends up in our serum. Or demineralization. At the end of the day, osteoclasts break down bone. And as a result of that, we get more calcium in our serum levels. So our osteoblasts, they do the opposite, right? They're the cells that are responsible for bone deposition and for building bone. And a lot of times we'll take calcium from our serum to do that, all right? So clasts break it down, and blast build. So kind of tuck those away, because those concepts will be essential as we're talking through some of the mechanisms of actions through some of these prototypes. So let's talk about these glands here. So your thyroid gland secretes, well, your thyroid gland has your parathyroid glands that sit right on top of them. Those four little, they look like little baby peas right here. These little guys are your parathyroid glands. And when we sense that your calcium level is too low, these guys kick into action. And they work by doing three different things. So they promote the release of calcium from our piggy bank, because they promote bone resorption here. So we get osteoclast activity, all right? They also work at the kidney level. So instead of that calcium being excreted from the kidney, they promote reabsorption. So it's back into our systemic circulation. And then they also stimulate the production of vitamin D, which, remember, we need vitamin D to absorb calcium, all right? So your parathyroid gland kicks into action when your calcium level is too low, and it does those three things to try to raise the calcium level, all right? So that's if calcium is low. Now, if your calcium level is high, your thyroid gland will release what's called calcitonin. And so this hormone will help to lower the calcium. It promotes osteoblast, or more calcium to the bone, and it will decrease absorption in the intestine, okay? So kind of taking a step back and looking big picture, we can see that our thyroid gland and our parathyroid gland are pretty important to the regulation of calcium. And so if we have some sort of disorder or dysfunction of our thyroid gland or our parathyroid gland, it means that we're going to have some sort of dysfunction or disorder with our calcium regulation. I used to take care a lot of thyroidectomy patients as like an off-service patient. Pretty quick procedure. They usually stay the night, go home the next day. But that surgeon was meticulous about making sure she had these standard post-op orders. And part of that was you gave calcium supplements at a certain interval post-operatively, because she was removing either part of the thyroid gland or all of the thyroid gland, which meant that some of those parathyroid glands were removed also. So the patient was at high risk for low calcium levels, especially right after surgery. And I'll share, just as a fun fact, you're not going to be tested on this, but sometimes what they will do is that they'll take these parathyroid glands and they'll reimplant them in the soft tissue of like your wrist, if you're going to have like a total thyroidectomy, and it's something that they can salvage. And that's to preserve the calcium regulation function of the parathyroid glands. So I think that's a pretty cool fact. Yeah, it is pretty nifty. All right, so these two hormones are essential, and also vitamin D. Oh, you've seen that before? Yeah, it's pretty cool. All right, so not to neglect our friend vitamin D here. So we can have vitamin D, we can get it a couple of different ways, right? So we can get it from sunlight exposure, and we get this inactive form. Or we can get it from dietary sources in this inactive form. And then when we consume it in this inactive form, it goes through a couple of different processes here to get to the active form. It has to go through the liver, where it's turned into this intermediate form. Then it goes to our friend the kidney, where it goes into this active form, right? And our parathyroid glands play a part in that also. But at the end of the day, we can either consume an active form of vitamin D in pharmaceutical nature via form of a pill, or we can get it via sunlight exposure or in our diet. The problem with dietary supplements and vitamin D is that they're, besides the fact that it's added to a lot of cereals and milk, is if you're looking at non-processed foods, it's kind of hard to find. So shiitake mushrooms are a pretty popular example. A lot of your oily fishes like salmon and sardines, and egg yolks are another one that I don't have written on here, but also high in vitamin D. Okay, now I will say also, your book kind of goes into an explanation of you can't have too much of a good thing, right? It is possible to have vitamin D toxicity. And if you think about it, a lot of those signs and symptoms correlate, or they're the same as signs and symptoms of a high calcium level, because if all of a sudden you've got a great vitamin T situation going on, you could likely have very high calcium levels too. So you don't need to know the name of it, just know that you can't have too much of a good thing, especially as we kind of get into our prototype in a few more slides. So here's the review. All right, so this slide should look very familiar because I copied it and pasted it from the previous lecture. So I think what you're asking, Abigail, is this active form of vitamin D, calcitriol, is different than the hormone calcitonin. Is that what you're asking? Oh, calcitriol. I don't know. I'll have to look into that, Abigail. It's a great question. I'll come back to that one. But we're going to keep moving for now. All right, so let's review here. No, it's a great question. I'm not sure if they're interchangeable, but we'll find out. All right, so low calcium levels are what we call hypocalcemia. We're going to review these common causes. They could be a deficit in your diet, whether it's low calcium or a low vitamin D, because a low vitamin D intake oftentimes results in low calcium levels. Malabsorption disorders, so whether it's something like Crohn's or the patient's having chronic vomiting, something that's causing lack of absorption. Decreased parathyroid hormone after surgery, so let's, just like we just talked about, if the patient maybe had a total thyroidectomy. And then certain medications. Does anybody remember which diuretic can cause a low calcium level? Our loops, so furosemide. Hold on to that hydrochlorothiazide for just a second. We'll come back to that. And as we're going to learn today, our bisphosphonates can cause low calcium level. Even though they build bone, that calcium gets stuck in the bone and they can cause a low serum calcium level. What about another drug you learned last week that can interfere with calcium absorption? Yes, Dylan, that's perfect. Yes. Yes, your corticosteroids can interfere with calcium absorption. Oh, well, thanks, Ms. Smith. All right. So with chronic kidney disease, yes, they have trouble making that vitamin D, and so then we have that calcium disorder. A lot of times, patients in end-stage renal disease, they have low calcium levels. They have high. What other level? Does anybody remember from the teeter-totter? If the calcium level is low, which one will be high? Phosphates. Yes, phosphorus. Perfect. All right, so let's talk about cats. So as we move through the rest of this discussion today, I'm going to say cats when I'm talking about low calcium levels, and I'm going to say back me when I'm talking about high, because it's just 1,000 times easier to say one word versus 4 or 5 different things. So make sure that if you didn't have a close relationship with cats and back me before, that you get reacquainted. Yeah. All right, so common hypercalcemia, common cause, it's highly associated with malignancy or an overactive parathyroid. So if that parathyroid gland is constantly on overdrive, it's constantly trying to raise that calcium level. This oftentimes is caused by a tumor. So overactive parathyroid could be problematic. Immobility is problematic because when patients are immobile, especially for a prolonged period of time, we get an increase in osteoclast activity. So there's a lot of bone breakdown, and then we have higher serum calcium levels. Now, does anybody remember which diuretic can cause a high calcium level? Yes, your thiazide, or hydrochlorothiazide was our prototype there. All right, so let's go through these signs and symptoms of cats and back me, just for fun and repetition. So for the low calcium, cats would be convulsions, arrhythmias, tetany, which are kind of like intermittent, like muscle spasms, and stridor. Stridor is really kind of like a muscle spasm of your larynx, right? So of those, which one would you prioritize treating first? If the patient had all of those symptoms, which one would be your priority? Stridor, right? Because it directly is affecting the airway. Great. All right, so for back me, we have bone pain, and that's because a lot of times, especially if it's immobility related, that calcium is leaving the bone, and we've got these weak, brittle bones left behind. Arrhythmias, which can certainly result in cardiac arrest. Sometimes with a high calcium level, the patient is more prone to develop kidney stones. And then we have muscle weakness, and then we have excessive urination on account of kidney injury. All right, so definitely review those if you're not familiar with them, because you'll likely see them again. So let's do a quick review here. Which clinical manifestation is associated with a low calcium level? Well, more specifically, which one pictured is associated with a low calcium level? So here's what we've got. So this one is actually Chvostek's sign here. That's where you tap on the face right here, and the facial nerve actually kind of twitches, almost like a little bit of tetany in the facial muscle. Trousseau sign is associated with a low calcium level, but what do we do when we're assessing Trousseau sign? What do we need? Yeah, that's the BP cuff, right? Right, and then you get that sort of flexion and adduction of your wrists kind of inwards. And then Babinski's and rooting reflexes, these are, that's PED stuff. You guys will learn about that in the third semester. So those were just distractors tossed in for fun there. Prototypes here, calcium salts. All right, these come in oral and parental forms. A lot of these oral ones you can buy over the counter. You don't need a prescription for, and they're pretty cheap and readily available. There's a chart on 75.3 or 75.3 if you want to look at all of them. These are probably the most common ones that you'll see. The big thing to remember is that with these, the amount of calcium that's actually in each one kind of depends on which ion or which element it's bound to. So calcium carbonate actually has the highest amount of oral calcium. However, it kind of boils down to you need to read the label, and you should tell your patients if they're starting one therapy and they're taking calcium carbonate every day, they don't need to all of a sudden switch to maybe calcium citrate, because it's going to have different levels. And it might not be what they need. So they are different. You just need to pay attention to the label and see how much you're getting. The oral calcium salts we use for mild calcium deficiencies. The patient might not be real symptomatic, or as like daily supplements. And then the intravenous or IM doses are going to be for those that are more severe. We use them typically for these diseases that we're going to talk through in a little bit, but oftentimes these diseases are associated with low calcium levels, right? So osteoporosis, Paget's disease, osteomalacia, there's that hypoparathyroid again, lactation. You actually lose a lot of calcium breastfeeding, and then heartburn, heartburn independent, with or without pregnancy, because heartburn happens a lot of times with pregnancy. Another way you'll see calcium salts, and I like this one, it's pretty cool. This is like a 2-for-1. The hyperphosphatemia we talked about with kidney disease. So they have that low calcium and that high phosphorus. We make a pill called calcium acetate, or Phoslo. And so they do get a little bit of supplemental calcium, but also it binds to the phosphorus in their foods. So they take this with meals, they get a little calcium supplementation, but also they get a phosphate binder that will help to lower that extra phosphorus that they're consuming. So I think that's pretty cool. With our IV therapies, with any electrolyte therapy, if ever given the choice to give it fast or give it slow, you always give it slow. Why is that? And this is generic across the board. Why do we give electrolyte slow? What's the biggest risk if you give an electrolyte too fast? Yeah, some sort of arrhythmia, which worst case scenario would end in a cardiac arrest. So the two examples of the parental forms are calcium gluconate and calcium chloride. When you do give these intravenously, you also have to be careful, because they can they're very irritating to soft tissue, and they're a high risk to cause extravasation. So you have to make sure you're monitoring the IV site when you're giving these. Our adverse effects are really going to be back knee, right? So if you, the biggest ones anyway. So if you give calcium supplementation and you overshoot your mark, they may have a high calcium level. So all of those back knees, right? I think the only one that doesn't directly relate to back knee on there is kidney stones. Key points to think about as far as drug interactions. So you'll learn about digoxin next semester. It's an antiarrhythmic, it's a cardiac glycoside, and part of the mechanism of action involves the movement of calcium. So this is just one of those things that if the calcium level is high, the patient's going to be at a high risk for digitoxicity. And when we give digoxin, one of the intended therapeutic effects that we want is a slower, stronger heart rate. But if they're experiencing too much of that, the patient could have bradycardia. As you learned last week, tetracyclines and fluoroquinolones can decrease the absorption of calcium. If we're giving calcium supplements to somebody who's receiving a calcium channel blocker, and this is another drug that you'll learn about next semester, amlodipine would be an example. If the mechanism of action is that we're trying to block the effects of calcium, and then we give them calcium, it can counteract those effects. Glucocorticoids, there they are again, right? They reduce the calcium absorption. And this is a review. Remember, your thiazides cause us to hang on to the calcium, and our loop diuretics cause us to waste it or excrete it. All right, so those are all kind of things to think about when you're giving calcium supplements. And then we touched on the food interactions, the oxalates in the spinach. So what do you have to do to spinach if you want to get maximum calcium absorption? You gotta cook it, right? And then all of these other foods are actually high in oxalates as well. So rhubarb, and I have to be honest, the only thing I probably have ever eaten rhubarb in is like dessert. I don't does anyone here eat rhubarb on a regular basis for fun? Is that a normal thing? Anyone? Okay, so but Swiss chard and beets also are high in that those oxalate contents. All right, everybody okay with calcium salts? You had it in a fancy cocktail. Oh, that sounds fun. Okay. All right, so everybody get your mobile devices out. We're going to go through a little exercise here, and this is you know, especially as you guys are heading into the second semester and you're going to be in clinical, you're going to be pre-planning, you're going to be looking at drugs left and right. So if you haven't gotten familiar with Lexicomp yet, I strongly urge you to do so. It's a great, great, great resource. So how do we give calcium chloride? Do we give it slow, like the tortoise, or do we give it fast, like the hare? Well, yes, we give it slow. But now, how slow? Let's say that you're taking care of a patient and they need an intermittent calcium chloride infusion, and the pharmacist is on break and you don't know how long you need to run it. We got to look it up. So you guys grab your Lexicomp and then type in calcium chloride. Let me do it with you. All right, and once it pulls up, grab the one under Lexi Drugs that says calcium chloride. And then once that comes up, hit that jump button, and it's in the top right. I actually updated a couple of little things on this PowerPoint this morning. So if you downloaded it before this morning, that says top left, but it's jump on the top right. And then select admin IV. And so how long does it tell you within that paragraph right there to give it? Yeah, over 1 hour. Perfect. So you can use Lexicomp for a multitude of things. Metabolic bone disorders. So we'll talk about osteomalacia, Paget's disease, and osteoporosis. So the first one is osteomalacia. And this is essentially boils down to a deficit of vitamin D, which leads to a deficit in calcium, which then leads to a softening in bones. And that softening in bones then leads to defective growth of those bones, and then skeletal deformities, bone pain, increased risk for fractures. So in adults, we call this osteomalacia. And in children, we call it rickets. I don't know why we have to have two different names for the same thing, but that's how it is. This is actually pretty rare on the account of, remember I talked about a lot of our processed foods are actually fortified with vitamin D. See it most often in either the super old or the super young. And those that are on strict like vegan diets or vegetarian diets, because a lot of times they're lacking that dairy aspect of their diet. Okay, everybody okay with this one? It is reversible. You can reverse it with supplementation. However, if they've had already some sort of skeletal deformity, that's not going to reverse. They will likely need surgery to repair that, but then they can get on a good dietary regimen of calcium and vitamin D to prevent it from happening again. All right, so Paget's disease. Now, remember I talked about this bone remodeling is always happening, right? But with Paget's disease, it's not happening at a nice homeostatic rate. What's going on is that bone breakdown and the bone building, they're happening at the same time, and they're happening at a very, very high rate. So that kind of rapid turnover leaves behind a really fragile bone. Does everyone with bow legs? That's a great question. I don't think so, Kelsey. I don't think it's all the time related to a vitamin D deficiency. When Ms. Klein gets here, we can ask her. She's our peds expert. Okay. And I think that she'll be along to see us soon, so don't worry. Just remind me to ask her. Yeah. I think it can. I just haven't researched it, but I would say it's. I'm certain that it can happen without. I hate to say I'm certain without an evidence base in front of me, but I feel confident that it can happen both ways. All right. So, anyways, Paget's disease. Again, it's still pretty rare in the scheme of things. A lot of times it's asymptomatic, and those that do have pain or do experience symptoms, it's a lot of times kind of these vague complaints of pain or maybe skeletal deformities. The cause is unknown, and it can affect a lot of times the hip, the femur, the skull, and the spine. Those are the most commonly affected areas. If it's affecting your spine, the patient is then at risk for some spinal cord compression and neurologic complications from that. If it's affecting any of the bones that are associated with hearing, the patient could have hearing loss. Headache is another kind of common one that's kind of skull related with this as well. All right, now on to the meat and potatoes of our bone disorders discussion. I feel as if osteoporosis is a big thing in the NCLEX world, especially when we get to our bisphosphonate. I feel good. I could like wager at least one of my kids knowing that to know that you guys would have at least one question on your NCLEX related to bisphosphonates. All right, so osteoporosis. What happens with osteoporosis is we get that bone breakdown. That's happening pretty fast, and then we really aren't having much bone building. So what's left behind is this kind of porous bone that's not very strong. And so these patients are at a really high risk for fracture. And this is the kind of fracture that like you sneeze and you fracture a rib. So everyday activity, could result in a fracture. So a lot of our interventions deal with prevention. And a lot of that prevention is stratifying your risk. So there's a few ways that we can stratify our risk. The first is testing for bone mineral density with what we call a DEXA scan. And this is called a dual energy X-ray absorptiometry scan. Way easier to say DEXA, but this is just like an external X-ray that they can use to really estimate the amount of calcium in your bones. The other way we can quantify risk is with what's called a FRAX scale, and this is a fracture risk assessment tool. I don't know why it's not called a FRACT scale, but we call it a FRAX scale with an X. And this is a way to kind of collectively take all of these risk factors below and kind of spits out this 10-year risk of fracture. And so these risk factors, age. The older we are, it's kind of like in your 20s and your 30s is really the prime time to be filling up your piggy bank with calcium, because as we get older, we start to lose bone mass. For women, we sort of experience an accelerated loss right around the time of menopause, and for men, it's a little later. With men also, they typically have bigger bone structures than a female, skeletal frame. So because there's more bone mass, for the most part, to begin with, it takes a little longer for that bone to break down and for those changes to show. And so a lot of these symptoms here with osteoporosis, you might not even have a symptom. So that's why it's a good idea, and you don't know about it till it's kind of like you've already got a fracture. So another reason why stratifying your risk is important. It happens in both males and females, but more frequently in females. Height and weight, this is really attributed to a lower BMI. However, your textbook says lower BMI, but when I think about it, I think higher BMI too, because, especially if it's immobility and lifestyle related too, right? If you have a family history of a hip fracture or rheumatoid arthritis, glucocorticoid use. So remember, chronic use of glucocorticoids is just never a great thing, especially, I think it's greater than 3 months is the timeline you guys talked about last week, puts the patient at a higher risk for all of these long-term effects, inclusive of osteoporosis. If patients smoke, and if they drink, and if they have already an existing metabolic bone disorder, such as maybe Paget's disease or osteomalacia of their hip, they're going to be at a higher risk for osteoporosis. So, we want to stratify risk. Would ototoxic disease, would ototoxic drugs be contraindicated in somebody with Paget's disease? That's a good question. Are you talking about because of the risk of hearing loss? Yeah, I like where your head's at. I like that you're thinking about it that way. It could just be, it would depend upon, what part of the bone it's affecting for them. So they might be higher risk and might need more, a closer follow-up if they're taking ototoxic drugs long-term. So that's a great piece to connect there. It's a good question. All right, so let's talk more interventions for nursing interventions for osteoporosis. So we're going to talk to our patients about risk factors, but we also need to educate them about appropriate dietary choices. So they need to diet high in what two things? Calcium and vitamin D. Great. They need to exercise, but what's probably the most important type of exercise to tell them they should do? Should they go swimming? Yeah, weight bearing. That resistance, any type of activity that requires some sort of like resistance or effort is going to stimulate osteoblast activity. So weight bearing, walking, running, yoga, yeah, anything that low impact, weights, weightlifting, those are all great. But if they're doing non-weight bearing exercises, it's good for their cardiovascular health, but it's not going to help them build bone. All right, the other thing to consider is safety, right? So let's say you're working on a geriatric unit and everybody there has osteoporosis. Now, obviously, we don't want any patient to fall, but should somebody with osteoporosis fall, they're going to be at a higher risk to have a fracture and a negative outcome. So what kind of things can we do in the hospital setting to make sure our patients are safe from falls? Non-slip socks, fall risk bundle. Ooh, that's good. Yep, side rails, clear pathways, making sure their call light is close, making sure their bed is low to the floor, making sure if they're altered, they have a room maybe closer to the nurse's station, using those bed alarms or chair alarms. Have you guys had to use those yet in your clinicals? They make chair alarms even for the toilet seat. So there's all kinds of safety precautions we can put into place. Okay. So these next few slides are some of our prototypes. We talked about vitamin D being important for absorption of calcium, and we can get it, remember, in inactive forms from sunlight or from dietary sources. But if we just want to go straight to it, we can take an active form, which is calcitriol, which, remember, this is kind of like a name alert here. Calcitriol is a vitamin. It's very similar looking to calcitonin, right? Which is a hormone. So remember, those are two different things, although they look very, very similar. So used chronically in disease processes associated with a low vitamin D or low calcium, which again would be our hypoparathyroid or our chronic kidney disease or end-stage renal disease patients. And when we replace vitamin D, we can do such a great job at that their calcium levels skyrocket because they're not used to having vitamin D, right? So it's keeping a close eye on those calcium levels, especially at the beginning of therapy, and being on the lookout for signs and symptoms of a high calcium level. So that would be, there's Bacamia again, right? And one of the things that we talked about with high calcium levels was the effects that it can have on digoxin levels, right? What were those? What do we worry about if a patient's on dig and they have a high calcium level? Heart problems. Yeah. What specifically? Which one? Bradycardia. Yeah. Okay. All right. And this would be contraindicated if a patient, before you began therapy had a high calcium level. All right. Our bisphosphonate here. I'm just certain you'll see this one in your future. So we'll spend some time here. Prototype here is alendronate. So the way that bisphosphonates work is they inhibit bone resorption. Now remember, bone resorption was with our osteoclasts. They're breaking down the bone and releasing it into our serum, right? Taking from our piggy bank and giving some away. Bisphosphonates block that from happening. So they block bone breakdown, which is great for bone mineral density, right? It means that calcium is going to stay within the bone and we're going to have stronger bones. Great, right? However, it can cause a low serum calcium level. So really important to continue to educate the patient. You need to continue with calcium supplements and vitamin D supplements and your weight-bearing exercises, right? Because while we're building your bone health, we might be kind of stealing from the calcium circulating in our serum. This is used very commonly in postmenopausal women with osteoporosis. It's used for male osteoporosis. It's used in Paget's disease, and then remember our glucocorticoids are going to cause a low calcium or inhibit calcium absorption, so they're going to be at a high risk for osteoporosis. Some of the big adverse effects, and this, even though it's there's a whole paragraph or two about it in your book for esophagitis, it's pretty rare that esophagitis happens. However, it can be severe, and this is the type of inflammation that's so severe it can cause esophageal perforation. We don't want that, right? So a lot of these key points that we're going to talk about are all in the name of preventing esophagitis and increasing absorption. It can cause a lot of GI upset too, actually, although that's not listed on here. That's pretty common. Muscle pain, eye pain, and ONJ, which is osteonecrosis of the jaw. And this is because there's some sort of link between there's really high bone turnover rate in our jaw. So that's kind of the random link there. They think that that's the connect. But this is essentially where your jawbone can rot, and you can die from sepsis, right? So prior to beginning bisphosphonate therapy, you want to make sure the patient has an annual dental exam and that they're following up with that on a regular basis. And if they have jaw pain, that they understand that's not something they should ignore while on a bisphosphonate therapy, that they need to let their provider know. So the big contraindication for bisphosphonates is somebody who has some sort of abnormality with their esophagus or the inability to sit up straight for 30 minutes. And because if they can't sit up straight and they can't swallow, that pill is going to get stuck in their esophagus. It's going to break down in their esophagus, and they're going to have esophagitis. So a lot of our key nursing indications here again, are to prevent esophagitis and to increase absorption. So bisphosphonates themselves have a pretty low bioavailability. And if you take them with anything in your stomach, basically 0% is absorbed. So it's really, really important that they're taken on an empty stomach. So here's how we give a bisphosphonate. If you start having jaw pain, can you keep taking it at a reduced dose? And I believe they would stop it immediately. The thing with bisphosphonates is that you take them and they're kind of like a part of you for a really long time. They stay in your system, you know, not at a therapeutic rate, but they stay with you for a really long time. So they likely would stop therapy immediately. Would somebody be NPO like a swallow study is done? If you suspected that there's any sort of esophageal or swallowing problem, certainly a swallow study is indicated, and bisphosphonate therapy would kind of take a backseat. They can be dosed intravenously, but you have to go somewhere to have that done, right? And that can be a barrier to some people. So with these, this particular bisphosphonate therapy can be dosed daily or it can be dosed weekly. There are others that can be dosed yearly. But this one is typically seen daily or weekly. It just kind of depends. There's a lot of literature out there. I read a few articles yesterday that were really showing the weekly administration was just as effective as the daily. And if you think about all these things that we're about to talk through, this is this is not a pill you just take and go about your day, right? You have to do all of these things that we're going to talk through below, which is you have to take it first thing in the morning when your stomach is empty, right? So no breakfast. Then you have to sit up for 30 minutes, take it with a full glass of water, and that's to just really ensure that that pill is nowhere lodged in the esophagus and gets all the way down to your stomach. And then you're sitting up straight for 30 minutes, just in the event that there's any sort of reflux, you're making sure that gravity's keeping it in your belly. And you need to do that for at least 30 minutes. That 30-minute time window also applies to food, and sometimes longer depending upon the literature that you read, but 30 minutes is pretty consistent. You need to have an empty belly or the drug will not absorb. We shouldn't be chewing and we shouldn't be sucking on these tablets. Again, that's going to increase the risk of esophagitis. If they're used with alcohol, it's going to increase that GI irritation and GI upset that can happen. And then remember, we need to encourage, you still got to take vitamin D and calcium. You still got to do your weight-bearing exercises and periodic bone density monitoring throughout therapy, whether it's yearly or every 2 years, kind of depending upon what literature you're looking at, but you need to continue to follow it up to make sure that the therapy is effective, because they might need to change a dose if it's not. All right, that was a lot, but I feel like this is a really important slide to sleep on. Questions about bisphosphonate therapy? Okay, just gonna keep going. Our next prototype is raloxifene, which is a selective estrogen receptor modulator, or a SERM. Also indicated for postmenopausal women, but the cool thing about this drug is that it can reduce the risk of estrogen receptor breast cancers. So this medication works on our estrogen receptors, and it works as an agonist in the bone. So basically it prevents bone resorption. And in the breast tissue, it works as an antagonist to prevent those estrogen receptor cancers. So this is a great drug, even if you're not postmenopausal, but you have a pretty high risk for estrogen cancers or estrogen breast cancer, you can take this as a way to help reduce your risk. And the big, so it works, absolutely. It works on your estrogen, receptors. So in the bone, it works as a agonist, and it helps to prevent bone resorption. Much like our bisphosphonates, right? They're preventing the breakdown of bone. But in our breast tissue, this is, a 2-for-1. This is great. In our breast tissue, it works as an antagonist, and it helps to prevent estrogen receptor cancers of the breast. Okay. And you also, so estrogen, so there's estrogen and calcium. So, after menopause, we lose the protective effects of estrogen that we get. And one of those is our calcium regulation. So after menopause, you may see, and there's, again, it kind of depends upon what source you're reading, you may see estrogen replacement therapy, but estrogen replacement is not without risk for really embolic events too, which is what we're about to talk about here. But really, it's that lack of calcium production as it relates to estrogen. So that risk is higher after menopause. So that's why you see postmenopausal throughout this slide. Does that make sense? Okay. All right. All right. You're welcome. So the big thing with our SERMs is this increased risk of embolic events. So if the patient has a history of a DVT or a PE, this is going to be contraindicated because there's such high risk to develop another one. They're also teratogenic. So, maybe this wasn't somebody who was postmenopausal, but they have a high risk of those estrogen-related breast cancers. They could be taking this at a really young age, and if they're thinking about starting a family, they may have to come off of this therapy while they're doing that because it will cause fetal harm. Why aren't men at risk if they always have? So men also, so testosterone eventually turns into a form of estrogen, and so as men get older and they have lower testosterone levels, they still are at risk because eventually they have lower estrogen level too. And as Dylan reiterated there too, they typically have bigger bone structures. And when you look at skeletal frames of male versus female, the males are typically bigger. So it takes longer for that breakdown or for the sequela of that breakdown to show. So that's twofold. Men don't go through menopause. And then on top of that, they have bigger bone structure. So men are at risk. It just takes a little while longer for those risks to show. All right. So big take homes with raloxifene, contraindicated if they have a pre-existing history of DVT or PE. They're going to be at increased risk of embolic events. They're teratogenic. Okay. Okay. Keep going. Practice question time. Client with a new diagnosis of osteoporosis has just completed a dietary education session with the nurse. Which statement shows this session was effective? I will eat less red meat because I love animals. I will decrease the amount of seeds and nuts I eat. I will eat more bananas to increase my potassium levels, or I will eat more dairy products to increase my calcium. Okay, we won't spend a ton of time here. You guys got this. While number 3 is true, it doesn't relate to osteoporosis and low calcium teaching. So more dairy to increase calcium. All right. Which teaching point will the nurse provide to a patient with a new prescription for alendronate? Take the medication with a full glass of water 30 minutes before breakfast. Take the medication with a snack or meal containing dairy. Take the medication immediately before bed, or take it with a calcium supplement. so here's what we've got. So number one is correct. We want to take it with a full glass of water 30 minutes before breakfast. What else do we need to tell them for that 30 minutes that they need to do? Sit up. Okay, so number two, take the medication with a small snack or meal containing dairy. So it's important to continue taking your dairy, but what's the problem word here? With, right? Remember that it has a low bioavailability, so they need to have an empty stomach. All right, so take the medication. What does that one say? Immediately before bed. Well, what happens when you go to bed? What do you do? You lay down, right? So is that a good idea right after taking your bisphosphonate therapy? No. All right. And so number four, take the medication with a calcium supplement. So here's the problem again with a calcium supplement. So you literally want nothing else in that belly while the bisphosphonate's in there. So if you have other medications, especially if it's a calcium supplement because it can interfere with the absorption, you want to make sure that you wait at least 30 minutes. In some literature will tell you up to 2 hours before you start taking mineral supplements. Anything you can do. Well, what do you guys think? What kind of nursing interventions can you do for GI upset? Anybody have any ideas? Oh, yeah, antiemetic. Okay, yeah, that's a good idea. Um, so not if it's intravenous, but that's a good point. You could do an intravenous antiemetic. Yeah, yeah, maybe reposition them, but still if they're in an upright position. So they can't really take Tums just yet. They have to wait until their belly's empty. Um, what do you guys think about non-pharmaceutical interventions for nausea? Really? Yeah, you could do ice chips because water isn't contraindicated. Yeah, smell, making sure that you decrease the smells in the room, right? Don't have the visitors come in with all kinds of smelly food. Um, Maybe delay having their food delivered. The GI upset, I'm glad you asked that question because it can be challenging to troubleshoot. And it's a lot of times why patients will change around their therapy. Some of them with the daily therapy, they can have a lower dose, so they're not maybe as likely to have the GI upset, at least as bad. But then you've got all that, those interventions that you have to deal with on a daily basis. Whereas taking it weekly, it's typically a higher dose, but you're probably at a bigger risk for those GI symptoms. So you may have to make a decision, is it best to deal with it for 1 day or best to deal with it for 7 days? And there are, other bisphosphonates, so sometimes it's just trying a different therapy to find one that you can live with. So those are great questions. So you know what, I think, do you guys need a break? How are you guys feeling? All right, let's come back at 10:07 and then we'll keep going. All right, it's 10:07, so we're gonna get back on track. I do want to loop back to, since we're talking about calcium levels in the chat, I did miss a point I want to talk about, and that is our calcium levels themselves. The typical level that we draw in the hospital, a random calcium level, that would be your total serum level, and that's not the most accurate way, believe it or not, to assess how much calcium is actually readily available for us to use. So remember, our bone is kind of like the piggy bank. That's where a lot of it's stored, but it's not readily available for use there. What's floating around in our blood is our total calcium level. And of what is floating around in our blood, about half of it is bound to things like proteins or ions. So what's readily available for us to use is what's called an ionized calcium level. And that's important because if the patient has some sort of underlying disease process, especially if they're critically ill and they have, either too high or too low of protein levels, it can affect the amount of calcium that's readily available. So there's, if you're really trying to get a good handle on how much calcium do I really have, what am I working with here? There's a couple of things we can do. We can do what's called an adjusted or corrected calcium level, which that involves a formula that takes into account the protein level of the patient to kind of give you a more accurate adjustment of how much calcium they actually have ready to go. Or you can do an ionized calcium. And the ionized calcium, it costs a little bit more and it's a little more cumbersome to collect. You have to put on ice and it has to go in a special tube. But that really is the best way to get the most accurate representation of how much calcium is readily available. So you guys will see that in practice, that you may see an ionized calcium level, or you might see it pop up that they ordered an adjusted or corrected calcium level. And that's because maybe they suspect some sort of protein, deficiency or overabundance that might really be affecting the true amount of calcium that we have. Or you guys may have already seen those. Has anybody seen those in practice yet? All right. Well, if not, you will. Don't worry, it's coming. No doubt you'll send it down not on ice. The lab will call you and say, you need to send it down again on ice. So anyways, joint disorders. We're going to talk about two joint disorders. You guys got a little preview into rheumatoid arthritis last week, so we'll take it just a step further this week, and then gout also. Now with rheumatoid arthritis, this is a progressive autoimmune disease that a lot of times will affect our joints, that synovial fluid and those tissues within the joint cavity. However, because this is an autoimmune disease, it's not limited to affecting just our joints. The patients can also have systemic involvement in any multitude of ways, whether it's weakness, fatigue, or fever. They can have cardiac and lung involvement. It really can affect any organ systemically. Quite common to affect the joints, but you can have systemic involvement because it's autoimmune. So with rheumatoid arthritis, especially if it's affecting their joints, it's very painful and can affect your ADLs. So our goals are really to reduce the symptoms, reduce pain, increase the functionality of that joint, right, and range of motion, so that we're not prohibiting their ADLs, decrease the risk of systemic involvement, and key to that is starting our DMARD therapies early, and slowing the progression of the disease. So our NSAIDs are a great choice for pain management for patients with rheumatoid arthritis or symptom management. However, they don't delay the progression of the disease. Corticosteroids also great at reducing inflammation and controlling pain, and they'll somewhat slow the disease process. However, what's the problem with long-term corticosteroid use? Is it good for your bones? Okay, what else? Yeah. Adrenal insufficiency, right? So it comes with any multitude of problems. So it's not something that you'd want to use long term if you couldn't. So now we have at our disposal what we call DMARDs. And DMARDs are our disease-modifying anti-rheumatic drugs. And these can be further categorized as either biologic or non-biologic. And the non-biologic that you guys read about, and it was a fair amount of it in your lesson this week, is methotrexate. It's relatively inexpensive. It's been around a really long time, and it's usually the first go-to. We're going to talk about a prototype called, it's a biologic today, adalimumab. So when you're treating rheumatoid arthritis, a lot of times you'll start maybe with an NSAID or a corticosteroid, and then the goal is to get a DMARD on board pretty quickly. The quicker you get it on, the slower the disease progression and the lower the risk for systemic involvement. So the thing with the DMARDs is they can take a few months to work, right? So a lot of times you'll see the NSAIDs or the corticosteroids while we're waiting on that DMARD therapy to really be effective. With gout, this is another joint disorder that is characterized by hyperuricemia or high uric acid levels. And this is either because we're producing too much uric acid or we can't excrete it appropriately, or any combination of the two. So we get these high uric acid levels, and that uric acid can then form these uric acid crystals that can get stuck places. Many times this is in a distal joint of the toe, and this is very, very painful. If anyone here has ever had gout or taken care of a patient with a gout flare, it's so bad, and it can be debilitating. Even though it's just one toe, can be debilitating. Does anybody know why it affects the toe most frequently? Anybody want to take a stab at that? No, not gravity. Ooh, Abigail's onto something there. Yeah, it has to do with circulation. So think about it, your toe is really the most distal area from your heart. So those uric acid crystals are actually somewhat temperature sensitive. So the colder they are, the more likely they are to form crystals. So if you think about your toe being the furthest away, a lot of times it's the coldest place too. So fun facts for trivia night. You won't be tested on that. But all right, our prototypes here. So our prototype, our biologic prototype for DMARD therapy for rheumatoid arthritis, or really any multitude of autoimmune disorders, is adalimumab. Adalimumab is what we call a TNF antagonist. So a tumor necrosis factor antagonist. And if you remember back to our immune system discussion, we talked about cytokines and how they're an important part of our immune system, and there's like 20 different kinds, and they have many different functions. And one of those functions is to help with the inflammatory response. Well, tumor necrosis factor is a cytokine. And so if on a normal day, TNF is promoting inflammation as a part of a normal immune response. But what a TNF antagonist does is it blocks those inflammatory effects of those cytokines. So we use it for autoimmune diseases such as rheumatoid arthritis, psoriasis, and you'll also see it used maybe for Crohn's or ulcerative colitis. This is dosed subcutaneously. It's not an oral drug, so it's pretty common to have injection site pain or irritation. Big teaching points is that these patients are at a big risk for infection and malignancy, and that's because we're suppressing their normal immune response. So heart failure, liver failure, those can happen, but infection and malignancy are way more common. So key points here is, do we give live vaccines to patients that are immunocompromised? No. So before you begin this therapy, you would want to check in with the patient and make sure they're not overdue for any vaccinations, and they could get them before therapy. You'll see a lot of times, if this is initiated maybe as an inpatient, the patient will be screened to make sure they don't have a latent TB. So you'll either see the PPD serum or a quantiferin serum draw just to make sure that they don't have a latent TB that could be reactivated when we start this adalimumab therapy. So you definitely would want to avoid if the patient has a current infection. You would delay therapy until that's resolved. We talk with the patient about the risk of developing cancer, and that's the risk versus benefits situation, right? If your rheumatoid arthritis is so bad that it's affecting your everyday life, maybe that's a risk that you need to take. And then this will be given subcutaneously, and it can be given at home. So the patients will need education on how to give sub-Q needles or injections, and to make sure that they're comfortable doing that. Some patients have, pretty big needle phobia, and if they can't do it, that's fine, but they need to have a provider or caretaker that can. So what are some tips you would give them when giving sub-Q injections? What would you guys tell your patient? What do they need to do? Rotate sites, that's good. What are some good sites? Yeah, where else is pretty, yep. Might be hard for them to get to that deltoid. That's more typically for your intramusculars up there. Yeah, the back of the arm is a better choice if you're going to use the arm. Yep, and you're monitoring those sites for signs of infection, so redness, swelling, drainage, fever. So adalimumab is biologic. It's relatively new in the scheme of things. Typically, the patient will be started on a non-biologic first, like methotrexate, and then if they don't respond well to that, they can add this to the therapy. Does anybody remember the cost of this therapy from their reading? It was pretty shocking. It was the yearly cost was estimated at up to $35,000 a year. So if you don't have insurance, that could be really hard to afford. This is a biologic, correct? It's a big part of it. Yeah, the non-biologics are still pretty effective. Have a lot of the same adverse effects, but they're substantially cheaper. All right, everybody okay with adalimumab before we move on? Okay. So these next three drugs are for gout, the treatment of mostly gout anyways. Our first one is colchicine, which is an anti-inflammatory. The mechanism of action is not really well understood, so not to worry, you won't be tested on the mechanism of action of colchicine. It can be used to treat a gout attack in higher doses, or it can be used as a long-term like preventative in lower doses. With all three of these gout drugs, they come with a high risk for GI upset. And that's inclusive here. There is a teeny risk of myelosuppression or myopathy also with colchicine. And then drug interactions. They can interact with statins and cause the patient a lot of muscle pain. And then these drugs that are listed below, I'm going to say some big fancy words. Please don't worry with writing them down and memorizing them. I'm just saying them so you can be exposed to them. But the drugs that are listed down here are what we call P-glycoprotein inhibitors or CYP3A4 inhibitors. Okay, and so what you need to know is because of the mechanism of action of these drugs down here, if taken with colchicine, the colchicine levels can be toxic. So if the patient's on any of these drugs listed here, you would want to second guess or look at a different maintenance therapy. And we do have other drugs available, so usually you have options. Allopurinol. Now this one's been around a long time. This is what we call a xanthine oxidase inhibitor. And xanthine oxidase is an enzyme that's needed to create uric acid. So if we inhibit that pathway, then hopefully we don't have uric acid created. And this has 3 approved uses, and that's for the hyperuricemia associated with gout. Can be used for kidney stones that are made of uric acid, and there are different types of kidney stones, but for those that are uric acid in composition, we can use allopurinol. And also it can be used in the chemo world. When we give chemo, especially to patients that have like solid tumors, those tumors will lyse as part of that therapy. And so the patients are at risk for what we call tumor lysis syndrome, or TLS. And when those tumors lyse, the contents of that tumor are then available to your systemic circulation. One of those contents is uric acid. So especially when initiating chemo, which there are certain types that it's a higher risk, but the patients are, you'll see prophylactically given fluid boluses and started on allopurinol. So if you're ever floated to a chemo floor, or if you work on a chemo floor and the patient's like, I don't have gout, why am I taking allopurinol? Because that's really what it's known for. You can explain that because they're receiving chemo and their little tumors might be bursting open, they're at a higher risk to have hyperuricemia. And so we're giving it to prevent those side effects associated with tumor lysis syndrome. So other adverse effects, that GI upset again, also some myelosuppression here. Does it have a physiologic role? I don't know. That's a great question because you can't actually have a high uric acid level and not develop any of these disease processes. So I'll put that on my to follow up list, Abigail. Yeah, no problem. You guys have lots of great questions. All right, so other risk here is this what's called a hypersensitivity syndrome, in which the patient would have fever, rash, and liver and/or kidney dysfunction. And then important points, and this is really with all three of these drugs, is taking them with meals will actually reduce that risk of GI upset. It's a pretty popular drug. I think you guys will give a lot of that throughout your nursing careers. All right, so our last prototype for the gout drugs is probenecid, which is a uricosuric agent. And essentially, this works by increasing the excretion of uric acid in the nephron. So our adverse effects, again, GI upset, rash, kidney injury, so we would avoid oral intake to help flush the kidneys. And this is one that just kind of one of those catch-22s. It's not used for an acute attack, so you wouldn't use it during the acute phase, but it could be used as a long-term agent for prevention. We'll interfere with our salicylates to decrease the effect. So if the patient's on any sort of salicylate therapy, you'd have to make a plan B. So our dietary teaching points for gout is that if the patient is drinking alcohol, this is not going to help their gout situation. Alcohol actually impairs the excretion of uric acid via the kidney. So they need to be advised not to drink alcohol. And then purine-rich foods. So this purine will actually eventually it'll turn into uric acid. So if they're consuming any of these foods here, they're not going to be helping their gout flare situation. So purine-rich foods, these are typically like your red meats, right? And then some of our seafoods, such like anchovies, sardines. Do people eat sardines for fun? I'm not really sure about that. I ate it once during a hurricane crisis, so I don't know if that would be my go-to seafood. Okay, and then I also listed, there's a link down at the bottom of the screen there. So you can go to that CDC website for more dietary information about gout. But alcohol and purine-rich foods are the big takeaways when you're talking to patients about their diet if they have gout. And just to kind of like flip back to gout therapy, if the patient only has like 1 or 2 gout flares a year, it can be managed very well with regular old NSAID therapy. But the more frequent those attacks, the more aggressive you need to be. And eventually, if they're having more than a handful a year, there might be a need to start some sort of long-term preventative therapy like allopurinol. They should avoid these foods, correct. Yep, all of those foods, that purine will turn into uric acid. So we don't want any more uric acid floating around in anybody with gout. All right, so practice question. Patient with rheumatoid arthritis will begin treatment with adalimumab. Which statement related to this therapy is correct? May lower immune response and increase the risk of infection and malignancies. It's okay to get the MMR, which is a live vaccine, while taking adalimumab. If you get a fever when taking, monitor for 72 hours and then notify your ND. Must be taken PO daily for 6 months. All right, well, here's where we're at. So the correct answer is number 1. So it's definitely going to lower their immune response. They're going to be a high risk of infection and malignancy. What's wrong with number 3? Somebody who's immunosuppressed, the patient, you want to say, let's wait it out for a little while and see how this goes. Right, they should notify ASAP if they have any sort of fever or sign of a fever, right? It's way too long. And what's the problem with number 4? Yeah, it's not given orally. And what's the problem with number 2? No live vaccine. Okay, so let's do another. Nurse is teaching a client about the rationale for administering allopurinol with chemotherapy. Which example would be the best teaching by the nurse? Stimulates the immune system against the tumor cells, treats drug-related anemia, prevents alopecia, or it lowers serum and that should say uric acid levels. It lowers serum uric acid levels. All right, so here's where we're at. Let's go through this. So number 4 is the correct answer. What's the name of the syndrome that we're worried about? Tumor lysis syndrome. Okay, and so for number 1, the mechanism of action, remember this is that xanthine oxidase inhibitor, which we need xanthine oxidase to produce uric acid. So we prevent the development, hopefully we prevent having excess uric acid. So it doesn't work on our immune system or the tumor cells. The chemo would be doing that. So this would be dosed prophylactically to reduce the amount of uric acid hanging out. Okay. All right, we're going to get to our next little topic here, which is the skin. Our skin has a lot of important functions. Helps to regulate our body temperature, it helps to regulate our fluids and electrolytes. What's another important purpose of our skin that we learned about a couple of weeks ago? Protects us. What do we call that? What kind of immunity is that? It has like 6 different names, right? It's innate, right? It's our innate non-specific immunity. Perfect. Perfect. All right. So get ready to itch. Sorry, I'm a little too excited actually to be talking to you guys about parasites. The 2 parasites we're going to talk about today are scabies and lice. So scabies are pictured here on the left. These are very, very tiny. You probably couldn't see those with, the naked eye. And they burrow into your skin. Gross, right? And then they lay eggs in your skin. even grosser. So typically they like to do this in these little areas of folds, right? So gluteal folds, in between your fingers and your armpits, and it causes some itching. And then you itch it with your fingernails, and then what happens? What happens to your skin if you're aggressively itching it? What can happen? What happens if oh, there we go, Hillary. Big risk for infection, especially if you're aggressively itching for long periods of time. You can open up that skin, get past our, first barrier of defensive immunity, and risk for infection. The thing about scabies is that even after you treat it, you can have itching for like a month or longer afterwards. Um, so lice, we can have lice in a variety of places, most commonly on your head. These are much larger, so you can see these without the naked eye, and they kind of look like these little scorpion-looking things, really gross. And so they need a host. They can live in your head if it's head lice, and then they lay these little eggs that we call nits. And those little nits kind of adhere to the hair shaft. So common treatment for both of those types of parasites is what we call permethrin. It's anti-parasitic. It causes paralysis and then death of the parasite itself, but not to their ova. So it won't kill their eggs. It's not ovicidal. Pretty strong chemical, so very common to have localized reactions when applying this, such as burning, stinging, itchiness, or redness. I don't think your textbook did a fair job of talking about some of these key points for permethrin treatment, so we're going to go through them because I think they're essential nursing interventions you should know, because you will see lice and scabies and beyond in the clinical setting. So key points here. When you're treating head lice, typically a shampoo rinse, such as the picture there, Nix, right? You can buy that over the counter. You don't need a prescription for it. When you're treating scabies, it's typically a cream. It's a giant tube of cream, which has to go usually from the whole body of the patient. So both of these are typically one treatment. Sometimes you'll need to retreat about a week out. But with the Nix shampoo, you want to wash the patient's hair first and then kind of pat it dry. You don't want to use shampoo because, conditioner, because conditioner will actually adhere to the hair shaft and then prevent really good absorption of the medication itself. And then with the permethrin cream for scabies, this needs to be applied for 8 to 14 hours. So it's ideal to apply that at bedtime for the patient and then have them shower off the next morning. So especially with head lice, that's only step one of the really fun adventure of head lice, right? So because of the ova that remain, especially with head lice, they can then hatch later, and you may do a shampoo, and then if you do nothing else, you're going to still have lice because the ova or the nits are going to hatch, and then you're going to have this whole cycle going again. So, I didn't get to that yet, Kara, but we will. So, this is really where the adventure begins, is that for up to 2 or 3 weeks afterwards, you have to meticulously, with a fine-tooth comb, brush out the patient's hair, trying to remove these nits that remain behind. And that can be very labor intensive. We experienced lice once in my family, and I have 3 little girls at the time. They were much, much younger. So getting a toddler to do anything you want them to do is challenging, let alone sit still for hours while you pick through their Rapunzel-like hair for 3 different kids. So it can be very labor intensive, manually removing those nits. Beyond that, you also then have to look at the environment. So these are parasites. They do need a host to live. However, they can live off of their host for a while they're waiting to pick up a new host. So anything that's been in close contact, such as bedding or combs or pillows, or at our house during that tragic time, it was a favorite stuffed animal. Those things have to be cleaned, and they have to be laundered in hot water, because that will kill the remaining ova or parasites. But sometimes things are hard to launder, right? So you can take those items and seal them up in a bag for about 2 weeks, because after about 2 weeks of no host activity, the parasite will die. Which even then at our house, I was like, let's just throw this away. We don't need this pillow anymore. We'll just get new pillows. We did have a situation with a favorite stuffed animal that was like, I couldn't wash it because it would have disintegrated. And even then I was like, oh, I don't want to take this out of the bag 2 weeks later. But she forgot about it, thank God. And it never made its way back into circulation. But I just want to relay that this is, just doing this shampoo to treat head lice is not where your treatment starts or stops. You have to comb the hair, you have to clean the environment. It's extremely laborious. All right, so other key points here. If the skin is open, especially if you're applying, this baby's cream, you wouldn't want to apply it to an open area because it can be very irritating. We talked about avoiding conditioner with the head lice. And in those with severe asthma, and that's just because it can be such a strong smell, especially with the shampoo, not so much the cream, but the shampoo, that it maybe could provoke an asthma attack. So make sure that you're doing this in a well-ventilated area. Open a window, turn the bathroom fan on, do it on your back porch. Make sure that you provide a little fresh air. So what do you guys think about if the patient has an awful case of head lice, but they are allergic to permethrin? What could we do? They're allergic to every type of anti-parasitic drug, so you can't even change drug therapy. Well, that would be one thing. That's one thing. Yeah, there's a handful of home remedies. Yeah, I've seen or read about mayonnaise. Yep. Yeah. You can wash your hair. You can also go to yeah, mayonnaise. It happened in the office. They used mayonnaise to treat their outbreak, but Meredith did shave her head. Maybe we should be watching The Office to reinforce this learning. So anyways, there are some other avenues you can go to. There's some lice centers around where you can go, and they will do basically a meticulous clean if you want like a no chemical approach where they wash and then remove with a fine-tooth comb. Or there's some places that use this thing that looks kind of like a hair dryer, and it basically dehydrates the parasite. The problem with those is that they cost like $200 and up. So you can go to Walmart if you don't have an allergy, and for $10 be done with your lice. Or if you want a more homeopathic take, you can go to one of these centers, or I guess you could shave your head and that would be free. But I guess we all have to decide what would be our best intervention. All right, questions about permethrin? All right. So acne, we're just kind of skim the surface of acne treatment here. Acne is typically an overproduction or blocked oil glands with our skin. So our prototype here is tretinoin. It's a derivative of vitamin A, and it modifies epithelial growth of our skin. So it's indicated for the use of acne, also for the use of fine wrinkles, so it has some cosmetic uses, or liver spots. You'll see it in many different forms. It's oftentimes mixed with different drugs. It's very popular to be mixed with antibiotics also. It's pretty strong, so very common to have these localized reactions of the skin drying out, blistering, peeling, pain, and will put the patient at a higher risk for sunburn. So I had this trending term down here in the right-hand corner of the screen. Back when the pandemic first started, I had some clinical groups and I was wearing my mask all the time and I was sweating and was getting all this acne just like right here in the picture. And so I went to my dermatologist and she's like, oh yeah, it's maskne. I was like, great, what? And it's this term now that they're using for the acne associated with, you know, acne that's developing under where our masks are. So anyways, she prescribed me some Retin-A. And nurses are the worst patients. Even though I read the instructions and I saw that it said high risk for, you know, blistering, peeling, a little bit goes a long way, use with caution. I also read, ooh, it also treats fine wrinkles. Yay. And having just entered my 40s, I was like, I'm going to use this for my fine wrinkles and my acne. And I really loaded up on this Retin-A therapy. And I'll tell you, within a couple of days, my family was like, what's wrong with your face? Because it was red and dry and cracked and all the things listed here. So the good news is that that won't last forever. You kind of build up this tolerance. And maybe, you know, worst case scenario, like a month into therapy, it gets a little better, especially if you use it as indicated. So things to think about when we're treating acne is that we have access to all of these lovely products over the counter, such as salicylic acid or benzoyl peroxide. So if you're using those before you start this therapy, you need to discontinue those because it's just going to increase the likelihood that you're going to have, you know, all of those localized reactions, the dryness, the blistering, the discomfort. And you want to make sure that you're washing with something pretty mild. And that this is the only you know, medication that you're using for acne at a time. And then wearing sunblock is also a really big deal. It's going to increase, you know, we should all be wearing sunblock anyways, but it really is going to increase your risk of sunburn. So putting on your sunblock, limiting maybe your sun exposure, you know, wearing protective, you know, hats or rash guards also, depending upon where you're applying it. And then again, we're always going to want to avoid an open area of skin for pretty much anything topical that we're applying. And this is not, treatment with this is not instantaneous. This takes a while. So it can take a few weeks to see results. So you have to be diligent about applying as directed and then being patient and then continue to apply. All right. So the patient is treated for head lice with permethrin. Following the treatment, the nurse will reinforce which instruction? Remain isolated for 48 hours. Inspect the hair shaft, checking for nits daily for 2 to 3 weeks following treatment. Shampoo with permethrin 3 times a day. Wash linens with cold water and bleach. All right. So number 2 is the correct answer. Remember, that's the really laborious part. We wouldn't do number 3 because this would be really excessive. It's typically once every 7 days. So 3 times a day, you're definitely going to experience some side effects if you do that. Problem here, what's the problem with this one? Number 4. Needs to be hot water, right? And then remaining isolated. So just because you have lice doesn't mean you need to be isolated. I was reading there's now this growing movement of, used to be if your kid had lice, you kept them home from school. It's not so much the case anymore. So it's probably not the time to be snuggling with anybody because close contact is how the parasites can be transferred. So you probably want to maybe not snuggle your friends, but you can still be around your friends. Maybe not share brushes or pillows, but you don't have to remain isolated. Okay. Name one education topic important to provide clients starting tretinoin therapy. Wear your sunscreen, right? What about our daily hygiene practices? Yep, avoid harsh cleaning. Perfect. All right, now we're going to get into our last little bit here, which is the anatomy of the eye. Now, this was one of the other little teeny changes that I made. If you downloaded the PowerPoint before this morning, I changed this image. I felt like this one was a lot more crisp and a lot more clear than the previous image. They're both the same. I think this one's easier to look at. So our discussion of the eye today is really going to be, let me get my pointer back out. I have a close up on the next slide, but we're looking at these little areas right here. So we'll skip here. So we're talking about glaucoma. There are many different kinds of glaucoma. These are just the two most common that we're going to talk about. And glaucoma is essentially a disease of vision loss that's oftentimes associated with an increased ocular pressure or increased intraocular pressure, which eventually will lead to optic nerve damage and blindness. And that increase in intraocular pressure is usually because of our aqueous humor. We either have excessive production or a problem draining it. And our aqueous humor is a fluid that on a normal day is floating around here, and it's helping to provide structure and shape to our eye, and it's bringing nutrients to all these structures as well. All right, so this is normal anatomy up here. This is the side view of your eye. This is your lens, and this is your iris right here. And it took me a while to kind of like look at this picture, but once I kind of figured out the angle, I was like, oh, okay, great. This is a great picture. It makes good sense. So if this picture disturbs you at first, it's okay. Just give it some time. Keep coming back to it. All right, so the other structure we need to talk about is down here. These are some of my favorite anatomy terms, is the trabecular meshwork and the canal of Schlemm. So this area is where this aqueous humor drains under normal circumstances. So we're going to talk about two different types of glaucoma. We talk about this open angle and this closed angle. And that angle that we're talking about is right down here between the iris and the canal of Schlemm, this angle over here. So this picture is an example of an open angle. You can see this little angle is open. And over here, this is a picture of closed angle. You can see there's no angle at all here, it's closed. So with open angle glaucoma, this one is actually pretty common. It happens as a normal sequela of aging, which is why it's a good idea to have your yearly eye exams, to get your intraocular pressure checked, and to have your optic nerve visualized. Did you guys do that in health assessment yet? Did you guys get out your little ophthalmoscope and look up the optic nerves? You guys been doing that? Yeah, that's fun, right? Okay, so with this type of glaucoma, it's also usually, there's no symptoms, right? So, oh, that's so sad. You guys done with health assessment? You guys need to get back in there. Look at the optic nerves. Find a friend who did it. All right, so pretty common, pretty normal, happens as part of aging, asymptomatic. And if we do our routine preventative health maintenance, we catch it early and we treat it. We have a lot of drugs we can treat this with. So what happens here is this aqueous humor, it's floating around like normal, and there's a problem with our canal of Schlemm and our trabecular meshwork. There's some sort of backup, so it can't drain. All right, so that's the problem with open angle glaucoma. This angle is open, we just got a drainage problem. With closed angle, okay, this is a lot more rare. It's typically on one side or the other. as a result of some sort of medication or injury or inflammatory process, or tumor that is displacing this iris, and it's displacing it enough that that iris has moved forward and now closed the entrance to our trabecular meshwork and our canal of Schlemm. So the aqueous humor can't drain at all. All right, so with this one, as compared to the open angle, it's a lot more rapid in onset. The patient has a lot more symptoms, usually inclusive of pain or vision changes. And this is usually needs to be treated with surgery. We do have medications we can give in the meanwhile, but typically this will involve a surgical intervention. And there's any multitude of surgical interventions. You don't have to know them all, but these are the key differences between the two here. All right, everybody okay there? Okay. So now on to the drugs. The other little teeny change that I made was that I removed the word miotic. There was a word in here which essentially means drugs that constrict your pupils. And that's not the best way to describe this drug. It's not the mechanism of action. So strike that from the record if it's on your copy, okay? This is timolol, and this is what we call, it's a beta blocker. So it's a beta adrenergic antagonist. That's a mouthful, right? Beta blocker, way easier to say. We'll dig into beta blockers from a systemic perspective more next semester. But remember, with our sympathetic nervous system, we have alpha and beta receptors. When we stimulate those, we get things like tachycardia and bronchodilation, all that fight or flight response that's going on. If we block those effects, we get things like bradycardia or bronchoconstriction. So it's important to understand that when we're talking about potential systemic side effects from this drug. Now, the way it works within our eyes is that it actually helps to reduce the production of that aqueous humor. So if we have less production, we have lower intraocular pressures. With all of these eye drops that we're talking about today, it's very common to have some local irritation, some stinging, maybe some temporary blurred vision that's pretty brief. But with this one, the big worry for us is if the drug is absorbed systemically, so bradycardia and bronchospasm. So patients that this would be contraindicated with would be those with existing asthma or other underlying lung conditions such as COPD, those with other underlying cardiac conditions if they already have bradycardia or any type of heart block. Sometimes beta blockers can worsen heart failure. So these are all things to consider when you're initiating therapy, and big reasons that we give eye drops in a certain manner to prevent systemic absorption, which we'll talk about that in a couple of slides. So big takeaway here, reduces the production of aqueous humor and the risk for those systemic side effects such as bradycardia and bronchospasm. And I'll point out too, a lot of the drugs that we're going to give today, there's so many different kinds. You'll see them in so many different combinations. There's a lot of drugs out there for glaucoma as far as an eye drop form. So our other prototype is latanoprost, and this is a prostaglandin. And the way that this prostaglandin works is that it helps to increase the drainage or the outflow of the aqueous humor. All right. So adverse effects here is that it can darken the color of your iris. It can also darken and thicken your eyelashes. Does anybody know what the brand name for that drug is? Latisse, yes. So this can actually be used for cosmetic reasons. Um, I have a friend who has beautiful eyelashes, but she always has conjunctivitis because it's one of the big adverse effects with Latisse. Um, all right, and so again, that blurred vision, that stinging, and the potential even for migraine with latanoprost. So, all right, key points here: increases the outflow or drainage, and then these pigmentation changes, whether it's to the iris, or your eyelashes. So let's talk about eye drop administration here. These key points. If the patient's wearing contacts, you want to have them remove the contacts and leave them out for 15 minutes so that we ensure that that drug is absorbed completely within the eye itself and not into the contact. You're giving multiple drops or multiple medications, you ideally would wait 5 minutes between each to make sure that each one is absorbed. We don't want to put any part of that eyedropper, we don't want to let it touch the eye because of the risk of what? Yeah, infection. Did you guys see any of the crazy, was it in your textbook or was it in HESI, the aids or the tools used to administer eye drops? I found those interesting. I've never seen any of those used in practice, the assistive devices to placing eye drops. Ms. Smith or Ms. Klein, have you guys ever seen those? I've never seen one. I've never seen a patient use one. I thought they were interesting.
I've never seen one.
Okay, well, anyways, it was fun to look at. Anyways, and then this is the big point here. Applying gentle pressure on that nasolacrimal duct. All right, and so I believe your textbook said 30 to 60 seconds. I believe HESI said 2 to 3 minutes. 2 to 3 minutes would really be the max amount of time that you would hold pressure. That's a really long time to hold pressure. But why are we holding pressure at that nasolacrimal duct? So it doesn't become systemic. Perfect. Okay. On our last prototype here, this is acetazolamide. This is a good drug to end with because it's kind of like a little variety platter drug too. It has a lot of different purposes, a lot of different uses. So for our discussion today, it's used for glaucoma, and this would be one that you could use with the closed angle glaucoma. But it also has diuretic purposes. So the other things that it can be used for, and I just think that these are fun to explore. So the way that the carbonic anhydrase works is when we inhibit it, we actually excrete more sodium from the nephron, which what goes with sodium in our nephron, what pairs together with it? Water, and then it's excreted. So it has a diuretic effect. It's not a great diuretic effect, but it does. It also causes you to excrete bicarbonate. So the patient can be at risk for acidosis. However, one of the cool other uses for this drug is that it's used to treat altitude sickness. And we tested on this. It's just a fun fact. I think it's fun to know. But when you're at higher altitudes, you have less oxygen, so you're breathing faster to try to compensate, and you end up with a respiratory alkalosis. So the fact that this drug can actually cause a little acidosis is one of the treatment, the rationales behind the treatment for altitude sickness. The other fun use it has is that it can slow abnormal activity within our central nervous system. So sometimes you'll see it used as an anticonvulsant. Specific to our discussion today, has diuretic properties, and we use it for glaucoma. And we use it for glaucoma because it will decrease the production of aqueous humor. And it can be dosed intravenously or orally. So adverse effects, paresthesias, malaise, fatigue, GI upset, and then electrolyte imbalance too. Remember we talked about way back at the beginning of the semester, use of our diuretics puts the patient at risk for electrolyte imbalance. What's the other this is now turned into a review. What's the other diuretic that we use that's used as a treatment for glaucoma? Yeah, mannitol. When nothing else works, we use mannitol. Why is mannitol a last resort? Why does nobody love mannitol? What are the risks with mannitol? Mm, no, there we go. Dylan's onto it. Heart failure. So it's an osmotic diuretic. It causes a lot of fluid shifting. If it's an effective diuretic, we could even cause dehydration, right? But also, if the patient maybe has a history of heart failure, we could put them right on into a pulmonary edema situation, and they could have fluid overload. And remember, do you guys remember we had to give mannitol in a certain aspect because it will crystallize at room temperature? So mannitol is sort of the last result because of all of these risks, right? It's pretty high risk. If nothing else works, then we would use mannitol for an acute intervention with glaucoma. And yes, you draw it up with a filtered needle and you give it through filtered tubing. Perfect. All right, let's do a couple practice questions. So the nurse is planning health teaching for a patient who has been prescribed latanoprost drops for open angle glaucoma. The nurse should include which of the following in the teaching plan? The drops may cause darkening and thickening of the lashes and upper lid. The drops may cause a temporary loss of eyelashes that will regrow once the drug is stopped. The drops will cause a decrease in aqueous humor production, or the drops will cause a permanent bluish tint to the conjunctiva that is harmless. All right, there we have it. The number one is the correct answer. So it can discolor the iris, and then it can darken or thicken those eyelashes. So that would be the opposite of that. And then for a decrease in aqueous humor production, what's the mechanism of action for this drug? How does it work? Yeah, it increases the outflow, not the production. Perfect. And then this blue is not blue. It's usually darker to brown that this coloring is, and it's not the conjunctiva. It's the actual iris or the eyelashes. All right. Appropriate administration is key for patients who are taking eye drops for treatment of glaucoma to optimize therapeutic effects and reduce adverse effects. The nurse would be concerned if the patient reports administering the drops in which manner? Into the conjunctival sac, holding slight pressure on the tear duct for 1 minute after instilling the drops, avoiding direct contact of the eyedropper with the eye, or leaving contact lenses in to be sure the eye drop is maintained in the eye. All right, so number 4 is the right answer. Just to recap, we want to make sure that we take contact lenses out for at least how long? After you get the drug? How long do you leave the contact lens? 15 minutes. You avoid that direct contact with the dropper. You don't want it to touch the eye because of the risk of infection. Holding pressure on the tear duct. So, you know what? This answer, holding pressure on the tear duct for 1 minute. I don't have a problem with this answer. I think I have to accept two. I have to accept two answers here. So really, it's the nasolacrimal duct, so which is all kind of in this same area here. And this 1 minute is within that. What did we say? 30 to 60 seconds for up to 2 to 3 minutes. So I will accept number 2. The nurse is concerned. Oh, thanks, Abigail. I was getting a little worried looking at this. So these are all right. This is wrong. So into the conjunctival sac is where it needs to go. We need to hold pressure for up to 3 minutes, according to our guidelines, in this area. We want to avoid direct contact, and the lenses come out for 15 minutes. All right. That is a wrap for today. Questions? Well, Mrs. Smith, do you want to answer that one?
Sure, yeah. So if you look under the week 16 final exams week, it tells you about the final exam. It is 75 questions. I believe in the week prior, there is a study guide already posted for you to start kind of gathering what you need to really focus on when you're studying. Now, please be aware this study guide is not 100%. Everything that's on the study guide is on the final exam. So that means that you should look at week 16 and look at all of those tips for increasing your success on this final exam. It is cumulative. It is over all the information we have covered this semester, but the study guide kind of helps you to condense some of your studying efforts. So please look in week 15, week 16 for all additional information in regards to the final exam. One other announcement that I wanted to just throw out there. So we know from our experience that the lessons in SurePath are a huge asset towards showing your success on these exams and your success on the final exam. And about 50% of you are spending less than a minute on these lessons. So my recommendation is to go back for any that you have really rushed through and really spend some time in those lessons reviewing that information, because when it comes to the end of the semester and students are coming to me worried about their grade, I can get in there and I can see how long you've spent on a lot of these required lessons that we have provided to you. And a lot of times it's less than 1 minute, less than 1 minute, less than 1 minute. And it's kind of the mentality of just do the as fast as you can to get through it and show that it's done. And that doesn't help anybody. These lessons are designed to really help you fully comprehend this material. And it's evident that a good majority are not really using them the way they are designed to be used. So I just wanted to throw that out there, that this is something that we are monitoring and looking at in regards to, is there a correlation between time spent utilizing these offered things and your exam grades and final exam grade, et cetera, et cetera. So the syllabus says it's 10% final. So it's 10%. Go off of what the syllabus says. I have not updated the study guide as of yet because we have not started developing the final exam. So the study guide is just, like I said, a very generic way to kind of gather some of the big things, the big content to study, but it is not 100% towards exactly what will be on the final exam. So 10%, please, and then we will update that study guide if necessary. Yes, so Arissa, the final exam is part of your exam average. So you will count the 4 exams you've had this semester, so the exam coming up next week, and then you will count the final exam as well. And I think there was an announcement or something in Cyber Cafe also posted about this for clarification as how do we determine this exam average. Ms. Klein posted a reminder, there's a review this Thursday at 4:30 for exam 4 in that PathoPharm Collaborate room. So for those of you that are stressing about this exam, this is a great review to make sure that you attend. Dr. Terzulli, did you want to clarify Kelly's question, or I can?
Hi, Kelly. No, so yeah, so you definitely want to pull down that lower eyelid, and you're aiming kind of really for in the center of that conjunctival sac. And then you want to put pressure on that nasolacrimal duct area to avoid the systemic circulation. I'll see if I can find a picture to put in the cafe too. I actually, was there a picture in the HESI skills? I can't remember. Anyways, I'll find a picture that will probably clarify better than words. I think the visual is in order here. You're welcome.
All right. Is there any other questions, thoughts, concerns that we can help clarify before we let everyone go for today? The exam 4 will be available for download by this Friday, and your team's invitations will also be coming out this week for you to confirm. So Tyler, Raynaud's is more an issue with nerve and circulation, nerve ability and circulation to those areas. So I don't think that would cause any issue with your uric acid levels. So I don't think that would increase your chance for developing gout. It's two different things causing those. And Gracie, after lecture or after the exam next week, we will do a final exam review. Breaking out a little game of Jeopardy. Any other questions? All right. Well, we hope you all have a wonderful week this week. Thank you, Dr. Terzulli, for that excellent lecture for today. And be looking at the end of this week for your ExamSoft download and your Microsoft Teams invites.
Hi, Tyler. This will be easier for me to just talk versus type. So it's not so much with gout, a decrease in circulation. It's just that the blood is colder by the time it gets down there. Um, so if it's colder, there's a higher likelihood for those crystals to develop.
I got you. That makes sense.
Okay. Can be given to patients with liver problems since. So it wouldn't be ideal, Dylan. That's a great thought because it's not really going to be metabolized appropriately. Great thought.